Ladies and gentlemen, welcome to already the fourth edition of the iPCI Imaging Club of this season. My name is Joost Daemen from the Thorax Center in Rotterdam, and it's my pleasure to be here together with Georgios Alexandridis, one of our research fellows. And together we will actually discuss quite an interesting case today. It's a case about a 6-year-old male that presented to our lab some time ago for complex coronary artery disease, at least we thought. But then a couple of things happened that you may find interesting. So the idea of today is that we'll discuss the case, we'll go into the details of the case. Actually, one of our fellows who was with us in the case, Parama Gandi, will do the presentation of the case itself. Georgios and myself will discuss a little bit on the IVUS images that were used. And then it's up to you to integrate into the meeting. Please use the chat function in the Zoom viewer to ask questions, or the raise hands function if you want to shout out or make any comments or statements. That's always welcome. So with that, Georgios, do you want to add something, or shall we give the word to Parama to introduce the case?
Yeah, so welcome everyone. It's our pleasure to have you all here with us today. As we said, my name is Georgios Alexandridis and we have Parama Gandi with us. So I think without further ado, I can briefly start introducing the case, and then Parama will give us his clinical perspective on the decision making that we did in this case. So today's case is a 60-year-old male patient which has hypertension, hypercholesterolemia. He smokes. He has also post-traumatic stress disorder, a pacemaker, and a positive family history. And he presented to our hospital with unstable angina.
Yeah. Sorry to interrupt. One thing is important, the PTSD, usually people would not pay attention, but in this case it is of interest, and you will see why within a few seconds. So don't forget PTSD.
Exactly. So in the ACG you can see the pacemaker, and let's go to the angiographies. So we started from the right, and you can already see in the right there is a lesion in the proximal RCA, and also a subtotal tight lesion in distal RCA just before the bifurcation. Then we continued with the spider view and the caudal view. So when it comes to the L6 and in the caudal view, we don't see any lesion, and we proceed with the cranial. And in the two cranial views, we can appreciate a lesion in the diagonal, which seems significant, and an intermediate lesion in middle AD. And yeah, so at this point, we had to make a decision how to proceed and what is the best solution. And perhaps Parama wants to explain a little bit about the strategy and the decision-making part.
So we have an intermediate lesion on the mid-LAD, and we want to be sure that the intermediate lesion on the mid-LAD is hemodynamically significant. And otherwise, because if we are facing a triple vessel disease in this case, with unstable angina pectoris, there would be a probability we can send the patient to the heart team meeting for the probability of either caveats or multiple PCI with high-risk PCI. Because this patient, we have to take into account he's quite young, 60 years old. The BMI was nice, 22, and also, yeah, so there's still probability of the heart team discussion. So that's why we want to be sure whether the implementation on the mid-LAD is significant or not. So we are going to proceed with the FFR first.
Okay. So for the people in the audience, if you have questions, comments, obviously a lot of options here with respect to next steps, but I think it's reasonable to proceed with an FFR of the LAD, because if this would be significant, yeah, that could drive you in the direction of discussing this young patient for a bypass with a bifurcation lesion in the LAD diagonal and long diffuse disease in the right.
Exactly, so we decided to proceed with the FFR in LAD, and we got a value of 0.87, so not significant, but we noticed that we had some difficulties in engagement, and at this moment also the patient became restless. So then in the next angiography we get this image. So we see that we have a almost total occlusion of the L6.
So Parama, what happened here?
So yeah, so the patient become restless and the doctor also become panic. No, I'm kidding. So yeah, as we can see, we can appreciate there on the CX, there might be a iatrogenic dissection because we try to engage with the EBU and we give a dissection to the CX. We can also appreciate that there might be almost no left main in this patient, or the left main is very, very short. So the engaging of the EBU there, because we want to do the FFR, we have to change it with a guiding catheter, which is the EBU in this case. But we unfortunately face this dissection. So, and then the next step, maybe we want to know what we are truly facing in this case here. Otherwise, we're going to be blind. So, in the next step, we are going to put intracoronary imaging, which is IVUS catheter in this patient.
Okay, but I guess you would, I mean, CABG obviously not really an option anymore at this stage.
Not in favor anymore, yeah.
So first step should be to recanalize the circumflex. Indeed, assuming this was a iatrogenic dissection of the guiding catheter, with which we had the issues to engage this LAD or left main with a very short left main. So what happened next? If you go
so
next,
we decided to go for IVUS and
so first recanalization of the circumflex, and then obviously the iatrogenic dissection, guiding catheter induced, so clearly an anterogate dissection with a high risk of wiring subintimal. And that's, I think, where the IVUS came in handy to at least establish the length of the dissection, the presence of hematoma, and to see whether for instance, hematoma propagated distally, and to see what, how the area of the LAD of the circumflex looked at this point.
Exactly. So with the red arrow in the angiography, you can see the starting position of the pullback. And now I think it's time to go to the IVUS pullback itself and appreciate what we can see there. Yeah. So as always, we start distally to review the case. So we can already see some plaque around 10 to 12 o'clock, but nothing important, let's say, at this stage, with a plaque burden of 40.
Yeah, so one thing, so for the people online, what you can see is that the distance from distal to proximal is exactly 10 centimeters. And what you can see that we only imaged 4.5 centimeters or 5 centimeters. That's usually not what we would recommend, because you would usually recommend for the first pullback to do the full length of the pullback. But the good thing about the IVUS is that you can start live imaging at the time you put the catheter in position. And then, at least in this case, you can already appreciate that in the first frame we see here, there are no major dissections or hematomas. So that means that, the pullback served its purpose here in the sense that at least we could ascertain that distally there was no clear dissections or hematomas anymore.
Exactly. So we continue with reviewing the pullback. So we're going more proximal right now.
So eccentric plaque between 10 and 2 o'clock.
Exactly. And then we expect somewhere to see possibly a flap, and then the hematoma and the dissection. So at this frame already, can we say around 12 o'clock that there's already some hematoma starting building?
I'm not sure. You see the wire?
Maybe can let it play a little bit first.
Yeah. Oh, that's Jurgen also online. Jurgen, welcome.
I'm here also. Yeah, I'm just...
Yeah. Yeah, so you say I see a flap, but I mean, it's an anterograde dissection, right? Because the guiding catheter disrupted the intima of the media from the adventitia, so that should be proximal. We're distal now, so in this case, I think it would make sense to start looking at I recommend the people to start distal and then scroll to proximal. But in this case, if you want to see the true damage, obviously that is proximal, and then you go from proximal to distal to see how much the disease or the dissection propagates.
Okay, so we can continue.
Yeah, just continue and see what you see. But the comment of Jurgen obviously makes sense. You can click on dynamic review to make the interpretation a little bit easier. So if you go to dynamic review.
Yeah, or just let it play once. You see that for the whole length, so that we can have already an impression, and then yes.
But here it's clear.
Yeah, there it's clear.
So what do we
That's,
see here? You see that?
Yeah.
So is this an artifact, Georgios, the black ring?
No, so the black ring here is the hematoma.
Exactly.
And also here, but we have different speckles, I think, so there is moving blood, most possibly, but I think we can appreciate the media somewhere here.
Yeah.
So that is, the hematoma is between media and adventitia. And when we...
So based on this image, so suppose the pullback would have started here, would you have been sure or reassured that you're in the true lumen?
No, we have to appreciate the whole length of the pullback, and we have to start also from a healthy part to see that we're in a healthy part in the true lumen and then go backwards.
Exactly.
Then go more proximal.
Yeah. Because Jurgen, I'm also looking, or let's say virtually looking at you. You would agree, right, that based on this image, you could not say whether you're in the true lumen.
No, yeah, based on this image, I have a suspicion that you're in a false lumen because I
Exactly,
see
that's
the
why I
true
was
lumen
asking.
there at 6 o'clock with no flow in there. You see the bright speckling of slow-moving blood, and that's very specific on this one.
Yeah, exactly. So that's why I was a bit. You see.
Now you can see that clearly. You see the non-moving blood, and I think that there is also some contrast media trapped in the false lumen.
Yeah, that's for sure. But here you see it nicely,
that's
right?
a black spot. Yeah.
See the calcium. Here you see the intima and the media. So we are in the true lumen.
Yeah.
And then here you see the dissection.
It's still in the true lumen.
Yeah.
But there is one moment that I suspected that you went in and out of.
Yeah. No, I totally agree. But the tip is here. It's like with any radiographic image, you screen from distal to proximal. Yeah. And here it's very clear. Here you see the wire of the LAD coming in.
Yeah.
Here is the ostium of the circumflex. We know the catheter is in the circ. You see also that the ostium is still patent. So the dissection is not exactly at the ostium, but is a little bit more distal, which is actually a good thing because that helps us in, if we want to treat this and stent it, we can let's say, safely land the stent at the ostium of the circumflex without compromising the left main and the LAD. Correct, Parama? That was the intention, I guess.
Yes, I agree with that suggestion, and we can totally see here that the wire is in the true lumen, and there is no intramural hematoma or dissection propagating to the ostium, so we can land safely just inside the circumflex.
Yeah.
Correct. Yeah.
So now Georgios has the easy part. He's going to measure a length and a diameter of a stent that he would use in this case.
Yeah. Important is just Joost for a remark that you end up in the true lumen. So then it doesn't matter that you have a short period of the wire in the false lumen because you can cover that. As long as you start in the true lumen and end in the true lumen, you're okay.
Exactly. Yeah. So we can use the IVUS to size a stent. Georgios, we're going to let you size, demonstrate to people online how to do that, and then Parama can tell us what he did.
Exactly. So as we said, normally we start from distally to decide what stent size we're going to use. But as already said in this case, so we already know that our proximal landing position, it would be right at the ostium of the L6. So we know upfront the landing position. So now we have to decide our distal landing position, and also to help us appreciate the distance between the two markers, we can enable the distance between the two functions. And so we're seeing here that we still have the hematoma. So that's not, of course, a safe position to land our stent. But I suppose around this part.
I would go a little bit more distal.
Yeah, you need a couple of millimeters distal to the hematoma.
You see there, this is beautiful positive remodeling with a round lumen. You see?
Yeah.
I think this just for safe that you have a very good landing zone. I would land here.
Yeah.
Exactly, and in the distal landing zone, we have a plaque burden of 40, so it's safe to land, and also we can appreciate the lumen area, which is above 5.5, and also the EEM area, and Yeah, so we would go for around 28 millimeter stent, and based also on the media, we would select around 3.0, right? 3.
Yeah, so the lumen is 2.6 to
yeah,
2.7.
Yeah.
I would not look at the 3.8 because that's obviously the maximum diameter, including the positive remodeling of the eccentric plug.
Yeah.
So if you take the lumen and round up a little bit, I think that is that would make
So around 3, I think it would be a good stent to use.
Yeah, exactly. Exactly. Take the lumen and
I
round it up.
I must agree with you that we want to stand it on, as distal as possible at this point. But unfortunately, at that point, we decided to go with a bit shorter stand, which method to 26 millimeters. So we didn't land distal enough. But I must agree with you because there is still quite small dissection and a big plug burden distal to the. We can see after the next front of the
Yeah. So if we can go back in the.
But this is very close, Parama, and that's of course the difference between offline taking all the time and in the heat of the moment quickly sizing. But if we redid it, I just redid it a little bit. We could have landed 1 or 2 millimeter more distal in the circ, and then I measured 26.3. So I think at the end this makes sense. So we stented it, okay, makes sense. 3026 direct stenting, and then what did you do thereafter?
Yeah, so if we can go back in the presentation, also for the audience to appreciate the angiography. So we see that we used a drug-eluting stent of 3 millimeters and 26 millimeters length, and then we have this angiography after the stent, and. Of course, to appreciate the result of our stenting, we decided to go for IVUS again.
Yeah.
So now let's proceed and evaluate the post-stenting IVUS.
Yeah. How is the patient at this stage, Parama? He recovered?
Yeah. He survived a bit for that moment.
Yeah, he survived, but what did he recover? Did the restlessness disappear? Or?
Yeah, the restlessness a bit disappeared, and then something wrong happened again after that.
Yeah, but we're not there. Yeah. Let's first look at the IVUS, second pullback.
So for the second IVUS pullback, we see that we start distally to the newly placed stent.
Yeah.
And,
please let it play. Yeah.
Yeah, just click play.
And here we appreciate from distal to proximal. Right now.
Yeah, there it is.
Yeah, you see the hematoma squeezed behind the struts. And then what is always important is to see whether you don't have this toothpaste phenomenon in which the hematoma propagates distally. But basically there are two things that we're interested in here. First, distally. Is the distal edge okay?
Yes. And so here,
despite what is this?
Yeah, this is an air bubble, so there's a common artifact on IVUS.
Yeah.
That's an air bubble in the catheter, eh? That's not in the vessel. Just sorry, sorry, because I heard this also before. It's not in the vessel. It's in the catheter. So it's always that you have to flush that the air bubbles between the probe and the inside are gone, because then you get these dark pictures.
Yeah, exactly.
Yeah.
And around this frame, we can see the distal stent edge.
Yeah.
Yeah. Ooh.
Yeah, but you see the jumping of the catheter, because if you go, so here you would say there's still some hematoma left, but if you go a couple of frames more distal,
you can see the stent struts here. But
here are stent struts, but if you go a couple of frames more distally,
there's your flush.
Yeah,
no, can I quickly, because I think. Yeah, there is indeed some hematoma left, huh? So here is some calcium.
Yeah.
But it's a weird image if you look at this, you see?
Yeah.
I'm not sure this is hematoma.
I'm afraid it is, Joost.
Yeah, of course, this is very likely, but...
Yeah, but problem is a little bit that you lost the image because of the insufficient flush. That's a little bit that's hampering the thing.
Anyway, distally looks fine. Okay. Yeah, and here you see, despite the imaging artifact, you see the lumen is somewhat shrunken. It's not optimal. It's not optimal.
No.
Okay, so what did you do with this image, Parama? More stents?
Yeah, actually, because we left a little bit.
Should we go back to the case?
Yeah.
Yeah.
So actually, because we thought, okay, it's finished with the circumflex, and then we want to do with the stenoticlation on the big diagonal. So we directly go there without making another step to go to put the IVUS catheter on the diagonal.
Yeah.
But we have one more IVUS pullback to appreciate the proximal part of the stent, because we missed that in in this IVUS.
Yeah. So if we go back to the IVUS, you can see that also the proximal edge, the catheter is too deep. So the catheter almost starts in the stent. There's a couple of frames, but I think you guys redid that. And then you see the pullback of the proximal edge. You can, you guys see that?
Yeah.
Aha, this is interesting. So what do we see, Jurgen?
So here we see the proximal.
Yeah. See the jumping of the catheter again? Yes. Right? Because if you see here... Oh, not really, not really. Yeah, here, so frame 133, we are outside the stent. And 138, we're in again. So that means the catheter is jumping a little bit in and out the stent at the ostium. Okay, that's fine. It's just for you to see. So don't get fooled by that.
And then here we see the wire from LAD.
Yeah, so the ostium is open, but the hematoma actually propagates towards the left main, right, Parama?
Yeah, that's a good point, actually, Joost. And then we decided to go with the diagonal. But this is a very interesting point, because finally, and then by looking at the next IVUS, we know that this might be the reason that something that we will not have been we will have not known if we didn't do the next IVUS run on the on the other vessel, because
two things are good if we can show the IVUS image again. So what is good about the ostium of the circ is that we don't see a clear dissection flap, meaning that this dissection is sealed, so to speak. So you would not anticipate that this dissection will propagate that much further.
But you can see some hematoma from 10 to 1 o'clock, which left unstented.
Yes, unstented, but I mean, there's no point in stenting a hematoma. The only thing is that you want to make sure, and this is the first frame in which we see the circumflex, and this actually looks good. And here's the stent. So the intima looks intact, and that means that you do not expect that this hematoma would I mean, this will resolve.
Yeah, we
at
didn't
least
expect
with respect to the proximal circumflex.
Yeah.
But then what happened?
Yeah, so without repeating the angiographies in the LAD, we decided to go directly for an IVUS on the diagonal. So in order to briefly recap, in diagonal we had a significant lesion and an intermediate lesion in mid-LAD with an FFR of 0.87. So we proceeded with IVUS in diagonal. So if we can go again to the IVUS.
Yeah, so I mean this changes strategy. So recall the FFR in the LAD was 0.87, right, Parama?
Yeah, correct.
So no need to treat the LAD. With that, cabbage to us was out of the question.
Yes, not in favor anymore.
Then obviously we were stuck a little bit with the dissection in the circ, and then we thought, yeah, okay, then better also see if we can and whether we need to fix the diagonal.
Yeah.
And also to see whether that was the culprit, because that's another reason why imaging in ACS is interesting, because you can see whether there are any thrombotic lesions or plaque ruptures, etc.
So let's proceed with the
And the
IVUS
patient
image.
was stable at this time, Parama?
Yeah, at this point, the patient is still not restless. But then after the IVUS, yeah, maybe I can tell after the
Yeah,
first.
we'll show you the IVUS first.
Yeah, yeah.
Yeah, so let's...
And the EKG, the patient had a pacemaker rhythm, right? So that also complicated a little bit the interpretation of potential EKG changes during the case.
The ischemic ECG changes.
Plus the fact that he had his PTSD, which made that he was already restless at the start of the case.
Yeah, that's a good point actually.
Yeah.
Yeah, at the start.
Not to find you excuses, but just
No.
Okay, pullback 4.
Yeah, let's go to IVUS and let the pullback play. So we can see it starts from the diagonal.
Looks healthy.
Looks healthy. Yeah, so we started from a healthy vessel. We see some plaque.
Oh, not too much.
Important.
Shrunken.
Yeah, we can see the wire from LED.
Again, an air bubble.
Entering the LAD.
Oh, what is this?
Voila.
What is this?
Very unexpected, surprising findings.
Yeah.
So, yeah.
What do we see, Joris? Can you take us through?
Yeah, so let's go from the beginning. On the diagonal, as you said, we started from a healthy vessel and we go more proximal to the diagonal. We can see already some plaque, but nothing important, around 12 o'clock. At this stage here, we see also the stenosis that was also visible in the angiography.
Yeah, so the lesion of interest, irrespective of any potential other findings, was at the ostium of the diagonal.
Yeah, and here as well.
So then you know that the bifurcation with the LAD is your anatomic landmark to orientate yourself within the pullback.
Exactly.
And that's very easy because here...
Yeah, so we see the stenosis here, and here we started already seeing the wire from LAD coming, so it means that we are in the bifurcation.
Yeah, so is the plaque significant? Is that a significant lesion here?
In the diagonal, yes, it is.
Why?
I think it's a very stenotic area with an MLA of 1.5 almost, plaque burden of 70.
Yeah, but Jurgen he said one word, and that word was important. He called it shrunken. And you see, it's weird, right? So the ostium of the diagonal, you have a lumen of 1.6 and a vessel area of 4.8. Whereas if I go distal, it's a bit bigger. So it's 5.1. Yeah. But you would expect that if there's a lot of plaque, that the vessel area increases. And that is not the case here. So for some reason, this is not the true caliber of this vessel here in the proximal diagonal. See? Here it's much bigger. So there is disease. Here there is disease, but yeah, it looks like there is some spasm as well. But you could say, if you would have said, yeah, MLA 1.5, plaque burden 70%, of course, those are two important markers for significant disease. That's true. Yeah, but no... I mean, this is not super high lipid-rich plaque with attenuation and
No,
there's clearly also no thrombus. So is this the culprit of the for the unstable angina? I would say unlikely, but okay.
Yeah, I think there is some mixed plaque.
Yeah.
And yeah, as we go more proximal, we see the wire of the LED, and now we're in LED. Again, I think some air, right?
Yeah. Some flush.
And after the artifact, yeah, I think somewhere here, yeah, we can see again the hematoma.
Yeah.
But at this point, I think we are not quite sure about the length of the hematoma, because we can appreciate it only in the LED when it comes only to the part more proximal to the diagonal.
Yeah,
so
correct.
We don't know how long it is or how far it extends.
Yeah.
And I think the image is kind of the same as we're moving more proximal. We see some fibrocalcific plaque, let's say, from 9 to 1.
Yeah.
But I think in the whole pullback here, as far as we can tell, we are in the true lumen.
We are in the true lumen, that's for sure.
I don't see that the catheter
So you
went
clearly see the three vessel
Yes.
layers, 360 degrees around the catheter.
Exactly.
And there is the circumflex again, right?
Yes, and
And
then
there
we
is
are
the catheter.
the catheter.
And you can yeah. May I put a remark?
Obviously.
You can see that this hematoma is probably the original is proximal in the, or maybe in the ostium of the left main, and extended both to the LED and the circumflex. And what is also interesting to see, and you can appreciate it even more if you go a couple of frames back in the ostium of the LED, that this hematoma is blowing up like a balloon.
Yeah.
And that means that is also a sign that you have a submedial hematoma, that one of the elastic membranes is broken. So, and if you cover the entrance of the hematoma, then this will resolve.
Yeah. Yeah, so that's tricky, Parama.
Yeah, and also we have to take into account that at this moment we felt like it is important, just like what Jurgos told us, that it is important to know where the propagation and the extension of the intramural hematoma distally to the bifurcation of the LAD and diagonal, but also the patient become restless at this point.
Yeah.
So yeah, let's see the next, and yeah.
Yes, so next we decided to proceed with an IVUS starting from distal LAD for the reason we explained, to appreciate the length of the hematoma.
Yeah, so a lot of people online may question what's the point in doing all these IVUSs. I would be happy to hear your comments, so please put them in the chat. But obviously the good thing is that with the imaging, and with IVUS in particular, there's no need to rerun cineangiographic images, which will likely, or let's for sure increase the risk of propagating the hematoma by injecting contrast with the catheters, potentially pushing into a false lumen. But with the pullback from the diagonal, we saw that the hematoma at least propagated until the ostium of the diagonal, but how much further in the LAD is not clear. So with that image by itself, I mean, you could not decide on the length of a potential stent, because you don't know whether this hematoma is stopped 1 millimeter distal to the diagonal or at the apex. And that's why I think the pullback you guys did here made a lot of sense in order to be able to measure the length of the problem in the LAD.
Yes, so if we go to our IVUS pullback and let it play, so we started from distal LAD, and we can see that here we are in a healthy vessel, so that's good. It means that we started quite distally. Some artifact as well, some plaque again from 9 to 12.
Yeah, here it's nice to see the discrepancy between the FFR and the and what imaging showed. So FFR 0.87. Now take one side step. So this is the distal LAD, right? A vessel with a diameter of about 3.0. And then you have plaque. And with 3.0, you have a vessel area of an area of about 5. But the area of the plaque, so that's the plaque we measured. It's about here. Plaque burden, 73%. Jurgen, vulnerable plaque or not?
No, I would say mixed plaque.
Mixed
fiber,
plaque.
fatty, and calcium here.
Yeah.
And if you are vulnerable, you may say that you have a fibrous cap there, but you also need to know the thickness of the fibrous cap, because then you have also that number gives an idea. And vulnerable, that means also that you need to know what kind of material is behind that cap, and we cannot see that on a grayscale IVUS. So I'm always a bit reluctant to call immediately vulnerable plaque. I just want to describe the things as eccentric mixed, and you can even say that there is a fibrous cap.
Yeah, Jurgen, I think you really nailed it. I totally agree. So with IVUS, you can see things, you can measure things, but whether this is a vulnerable plaque is difficult to tell. The only thing is you can describe the features. In this case, a sign of vulnerability is the plaque burden, 71%. Everything above 70 is a sign of vulnerability. Then there's calcium. There's no low attenuation plaque, so is this pure fat? Likely not. There's here some calcium in the cap that suggests that this plaque is relatively stable, but obviously that's at this frame. Whether this is a thin cap fibroateroma, obviously is something you cannot say based on IVUS. The only things you can say is minimal lumen area. Well, in this case, that would be 1.7, so that's small. It's interesting, right? Usually if the FFR, the lumen area is above 2.5, then the FFR is negative. If it's below, it's likely positive. But with an area of 1.7, if I would have known this, I would have said this lesion is significant based on FFR. So you see here a nice example on how these findings typically do not correlate that well. And particularly as this was a patient presenting with an acute coronary syndrome, it may have been that if you would have looked with OCT that there may have been a small rupture or erosion here, which would have explained the discrepancy with the FFR as well. Anyway, so that's a little bit more on the culprit, but then you proceed with the obviously reason or second reason why we did the pullback.
Yeah, and of course we can see what we expected. The hematoma here is clear, and as we move more proximal, we are in the true lumen, as we said. And we can see really nice the hematoma that it is behind the media.
Yeah. Substantial, huh?
Yeah, which extends all the way to the ostium of the LAD and the very short left main.
Yeah. Oi, Parama.
Yeah.
Now what?
Yeah.
So the patient became restless again, and we decided to directly put a stent on it. Can Georgios please do the measurement of the necessity of the stent? So
so if we go again to the IVUS software, I think we will all agree that we are going to land as proximal as we can in the ostium of LAD to cover the hematoma, but including the hematoma and the lesion that we recognized, I think we should, it's quite a long lesion.
Yeah, so here's nothing, so you can go more proximal, I would say.
Yeah, but with the air, we cannot really appreciate.
Yeah, right here, a bit here,
Yeah.
This looks good. So 51.
Yeah, so I think we can...
And that is taking into consideration that you don't see the ostium.
No, that's pity.
So I suppose we, as also the operator decided to proceed with the longest stent with
the longest stent available is 48 millimeters. So we can see that the distal reference is 2.9. We took the 3.5 millimeter stent with the length of 48 millimeter, and we put it from the mid to the proximal.
Exactly. And if we can show also the presentation for the audience to appreciate where exactly we place the stent. So we use the drug-eluting stent of 3.5 millimeters and 48 millimeters length, and you can see it on the left. And also we did a post-dilatation in the ostium with a non-compliant balloon of 4.5 millimeters. And after this, we did another IVUS run in order to show, if we are happy with the results of the stenting or if we missed something. So I think we can go to the IVUS again.
You stayed in LAD with the stent, eh?
Say again, Jurgen?
Did you stay in LAD? Or you plan to go over to the left main because of the left, yeah?
Yeah, Parama, was there a left main?
I didn't see a left main actually.
So it was almost a separate ostium, right? I think there's 1 or 2 millimeter left main.
Yeah.
But I think the operator here crossed the circumflex. But we'll see that on the post-PCI pullback.
Yeah.
Okay, so
at least I hope we see that.
So let's run the pullback. So we see that we started more distal.
Because otherwise you almost have a V.
Yeah, we started more distal than the place that we stent, so that's good in order to appreciate the whole part.
Yeah, looks good.
Here, as we can see, we're inside the stent, and behind the stent there was some hematoma.
Looks good. Looks good. Yeah.
There's the aorta.
And now, perfect.
Yeah, so we covered the whole thing. Where's the ostium of the circ? Do we see that?
Yeah.
So the stent is protruding 2 millimeters or 1 millimeter in the aorta.
Yeah.
But that's okay. But then it's difficult to see the circ. Yeah,
you have a wire in the circ?
Yeah. Say again?
Do you have a wire in the circ still? There's a circ. Yeah. There's a circ.
Must be there. Yeah.
12 o'clock.
Yeah, but it's at least nice and patent for at least as far as we can tell. Okay, so LAD saved.
LAD saved, but we did another angio. Can you show us to the audience?
Yeah, but before we go to the angio, perhaps we can appreciate the distal edge of the stent to see if we're happy with our result or not.
Yes, that's what I want to tell you as well, because I can see that there is still residual significant stenosis on the distal to the stent with if you can put the bracket there, maybe we can see the minimum lumen area.
Yeah.
Yeah, so eccentric plaque.
Yeah.
A little bit of spasm maybe.
But here we have a lumen area around 3, but there is some spasm, right?
Yeah.
Yeah.
Yeah, so this is typical. If you land the stent in a plaque, then you may see some spasm, and that's so. Then it's just a couple of millimeters sometimes, and those cases I always find difficult. Jurgen, also to you to.
Yeah.
I mean, you can pull the wire, give some nitrate, repeat the imaging, but in my experience, most of these cases, if you shoot an angio, those are the cases in which the edge looks ugly.
Yeah, I'm looking at 3 o'clock is a sign of an edge section, but it's not that very impressive, I think.
No, it's not. It's not. The only thing that you can say, and I think that's important, is that the lumen area distal at the distal edge here is small, plaque burden 60%, whereas distally it's 5.1, which is clearly a lot better. So did you?
What's the nitrate? Were nitrates given?
Yeah.
Okay.
At least I think so. Parama?
I actually didn't remember this patient, but I think we gave it.
Because that would be.
Yeah.
So if we go back to the presentation and
anyway, what would be an argument anyway? Sorry to keep interrupting you, is the fact that the edge has a plaque burden above 50%, and that's something we know as a predictor of stent failure. So everything with above 50, and specifically here it was 60 at some point. That's basically too much here. So that could be an argument by itself to put an additional stent, specifically if the distal landing zone like here That looks much better. Yeah.
Yeah,
Okay.
so, we agreed to put another stent distal to the proximal stent
If you
because
can go back to the
So
slides.
if
Yeah.
we go to the slides
Yeah.
and the angiography.
Yeah, because it's clear from the IVUS that the minimum lumen area is small, lower than 3, and the plaque burden is just like what Joost have told us, more than 50%. So we measured the necessary of the stent there because the distal difference is around 2.6, 2.7, and then we put a 3 millimeters with the length of 13 millimeter stent to also overlap a bit on the proximal stent.
Yeah, and what is interesting is that if you would think a little bit one step back on the pre-PCI LAD IVUS, we measured 51 millimeters. So it was a little bit ambitious to think that a 48 would be sufficient.
But did the post-standing IVUS here change the decision plan? So because in the IVUS, okay, we had the increased plaque burden at the distal stent edge, but to my perception also in the angiography, if we only guide it through angiography, it doesn't really look nice, the distal part
absolutely.
of the... So I think if we only used angiography, the decision would be 100% to stand more.
Yeah.
But on IVUS...
And what I think is important also to realize that if you would have seen this image, if you would have stented the proximal LAD, you would have said, well, I missed the distal edge or it's spasm. But in this case, there was disease. Second, it looks ugly on angio. But third, this could also have been the propagation of the hematoma. And then the decision to put an additional stent could have been completely different, because if it now we observe plaque, but if this was just hematoma, I would have perhaps considered refraining from an additional stent.
Yeah, it's another reason for checking with your IVUS or OCT, Joost. Just in this,
Yeah, exactly.
Yeah, we don't want to put a stent to the whole of the intramural hematoma just because of the sole reason of the EMR.
But in any case, the operators used an extra stent, and then, after standing L6 and one standing in L6 and 2 stents in LED, we went to the diagonal, which we thought, or at least in the beginning, it didn't seem really nice in the angiographies, and at this point, they proceeded with a non-compliant balloon in the diagonal. But perhaps, Parama, here, you would like to comment how the whole complication changed your procedure plan, or what happened in the cath lab?
So to take a step back to the first beginning, the patient was fairly stable, and we would like to consider if this was to be a triple vessel disease and an acute coronary syndrome, then we have to put into account that maybe this patient could be better to have a CABG. But now the scenery has been completely changed, and due to the complication of the intramural hematoma and propagation extending to the LAD as well, that was not expected before. And there is still some serious a disease on the ostial diagonal as well, and to also appreciate that the diagonal is a big vessel, it will always refers. It vascularizes a big myocardial mass on the anterior heart. So what we did next is we want to open the strut towards the diagonal with a pre-dilatation performed using 2.25 15 millimeters non-compliant balloon. And then we intentionally avoid to do a bifurcation stenting on this patient and to just give the patient with a drug-coated balloon there, given the procedural complexity. So we didn't do any bifurcation stenting eventually.
So if I understand correctly, you decided to do lesion preparation or a pre-dilatation with a non-compliant balloon, and then you treated the patient with a DCB of 2.5 and 20 millimeters length. And this is the angiographic result after the DCB. But perhaps here, Joost, I would like to ask you, would you consider a DCB in this diagonal if you didn't have the whole complication in the L6 and then NLAD? Or here it's you would go for standing in this diagonal up front?
Yeah, so a couple of comments. I agree with you, this diagonal, and now of course, due to the whole situation, it may look a bit smaller, but it's at least a 2.5 to 275 diagonal, so I agree with Parama. It's a reasonable sized diagonal. It's Medina, yeah, based on the FFR, you would say maybe only 001 classification, but in this case on the IVUS it actually was a Medina 111. So this was actually a true bifurcation lesion. Bifurcation stenting, provisional stenting, 2 stent, 1 stent. This is also a little bit of a personal opinion. I think in 95% of the cases a 1 stent strategy, specifically if it pertains to diagonal branch, is better. Or at least I'm not convinced that a 2 stent strategy for an LAD diagonal bifurcation is per definition better. The only downside in this case that I would like to advocate is that DCBs are indicated in case you have diameter stenosis of less than 30% after the predil. And I'm not sure that criteria was met here. You can see that the balloon nicely opens, you guys recrossed, opened the struts. But then even after the DCB, there's still at least a 50% stenosis at the ostium of the diagonal. I get what happened. There's TME3 flow, so I think I would completely concur with what happened here. But whether in the optimal world you should have accepted this, I think nobody knows the definitive answer. But I think it's a reasonable result. There's TME3 flow, LED looks nice, diagonal is patent. There is some plaque in the ostium, but whether that would be better off with a small stent, I'm not convinced. So yeah, it's my opinion.
Okay, so yeah, I think in the left you can also, we have a caudal view. So in order to see a final result in the circumflex.
Yeah. Yeah, so also the ostium of the circ is a bit pinched. But that, I think, refers to Jurgen's question that you stand until the ostium in the LAD. Yes, we did. And although the LAD was very short, 1-2 millimeters, the ostium of the circ got pinched a bit. But also here there's TME3 flow. So I think that's the best you guys could do at this time.
Yeah. And so in order to remind you, with the pre-PCI angiographies, except from the left side that we already discussed, also in the right, we had 2 significant lesions, but given also already the complexity of the procedure and I suppose the timing, here you can see the pre-PCI angios, and in the next slide the operator decided to proceed with standing directly without any pre-PCI IVUS, and they selected to stand with a drug-eluting stent of 3 millimeters and 13 millimeter length in distal RCA and 40 millimeter in proximal RCA.
Parama, what was the rationale to proceed here? I think a lot of people would have staged this, right?
Yeah, because this is actually we don't know very sure which one is the culprit lesion. But yeah, from the trial, it shows out if the patient we can put complete revascularization. So we want to do that, and also considering that the patient has a PTSD, I would not want to have this patient in another
session. I think that's I would completely agree. So those are 2 very good arguments. One is we were not sure whether you treated the culprit, and this was not a candidate that was somebody who would be very happy to come for a second time. So no, I think it makes sense to proceed here. Was the patient stable at this time?
Yeah.
Yeah. Okay. Well.
He's happy.
Yeah, and that also explains probably why no PCI IVUS was done.
Yeah. We only do the post PCI IVUS.
Okay. So this was quick and dirty angiographic PCI. Which may also work in some cases, as we learned recently.
It's reasonable.
Yeah, already you can see in the angiography the final result, but let's go also to the IVUS to appreciate the post-standing result. So we are in the RCA, we start distally, but we hadn't captured the starting position of the catheter, so we don't know in which of the two vessels.
Oh, good.
Yeah. We already saw the first end, and now we're going more proximal.
Yeah, so this all looks good, not too much plaque.
Right.
Ah, there's the stent.
Good.
Looks nice and round, properly expanded. Yeah. Ah. Yeah.
The last edge, but
yeah, here.
Yeah. I see a bit malposition there, but it's a couple of struts only.
Yeah, exactly.
Yeah.
So this stent looks good. Yeah. All right. Good.
I see that they re-prepared the catheter in between.
Yeah.
Yeah.
After 6 months, they got the air out.
Yeah.
I saw that the company now has this alpha cross catheter, and they redesigned the whole stuff, and they actually now even will provide you with a new syringe with 2 ears on the back. I tried it at PCR, and I have to say that the flushing became a lot easier. It takes you a lot less force, and according to the company, it's really going to help in avoiding these air bubbles, which is a problem irrespective on how well you flush it. It keeps occurring.
The thing is, Joost, and when I was there, and when I was there, with all these mechanical catheters, that is Boston, that is System, that is also the revolution of Philips. You need to prepare them well, and actually you have to take some time to make a protocol of that. You can have several protocols, the 3 steps, what we used to do, etc. But you always have to take the time for that, and then you have most of the time a good result.
That's correct. Yeah, but not always.
Yeah, you see, and if you look in the papers of the companies, I always tell also the companies they're written by marketing people, and they only want time. And that last part, to save time, forget it. If you take your time to do the proper flushing there, and then you save time during the procedure because you don't have to redo these things. That's one thing that I want to give the audience if they like to do as a take home for technical thing for the IVUS. Second thing what I wanted to give home, because what I also saw in this, if you want to see the ostium of a vessel, don't forget to withdraw a little bit your gynae catheter. Because in this case, and you saw that Parama, that probably would have helped that you would see this ostium before you place that stent. So then you could have a good proper placing or good length decision, because that you were in the blind because you saw the catheter in there. But that counts for everything, because I see this in many times. Yeah, sorry guys, because you can take the man out of the imaging, but you cannot get the imaging out of the men, so that's why I'm talking.
Jurgen, that's why we love to have you.
Much.
And you're 100% correct. You need to take the time to do the flushing, like with all the things we do, and obviously pulling out the guide is a more elegant way to image the ostium. That's absolutely without any arguments. All right. In the interest of time, we have 2 minutes left. What happened next? Or we're at the end of the case? Yeah, so one thing, Parama, thank you for being with us and explaining.
Thank you, Jurgen.
I cannot avoid to show you one more slide before we continue. And that's this one. I think we recently demonstrated that angio-based physiology is something that is likely here to stay. Now 2 trials published in New England 2 months ago, in which we demonstrated that angio-based physiology is as good as compared to wire-based physiology to guide PCI of intermediate lesions. If you would have avoided the guiding catheter, you would have avoided the pressure wire, you would have avoided complications, you would have avoided 3 more stents and a drug-coated balloon. And this patient would have been referred from PCI with a VFFR in the LAD of 0.82, which I think would have saved the operators in this case a lot of time. So I think this is a beautiful case to demonstrate how angio-guided or angio-based physiology-guided PCI could have dramatically changed the course of cases like this. So with that, I think we can conclude this case. We would like to thank you for attending. Thanks, Jurgen, for your input. Thanks, Parama, for being with us and presenting. Thanks, Georgios, in all your work in helping us to prepare this. And thank you all for watching.
Thank you, everyone, and see you in the next session.
Thank you. Bye-bye.
Bye-bye.